Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
This episode is our second episode in the radiation oncology series. Today, we're going to be discussing complications and toxicities of radiation therapy. Sydney, what are our learning objectives for today?
Our learning objectives are to 1, acknowledge that treatment with radiation therapy in gynecologic malignancies is common and carries unique side effects compared to those of chemotherapy. To identify the difference between acute and chronic timing of radiation side effects, to recognize the most common and rare side effects to the urinary tract, GI tract, vagina, ovaries, bone and bone marrow, and skin, both in the acute and chronic settings, to understand that radiation side effects are often driven by the site getting irradiated, volume of tissue exposed, radiation dose, type and method of radiation, and degree of pre-existing disease or comorbidities. And lastly, to recognize the radiation emergencies of uncontrolled hemorrhagic cystitis, bowel perforation, and vascular fistula or GI bleed, and of course, how to manage them in the emergent setting.
Let's get started. In our last episode, we discussed that radiation induces cell injury by DNA damage through generation of free radicals. This effect is more profound in rapidly dividing tissues. While treatment modalities have advanced over the past decades, allowing us to use imaging and delivery techniques to minimize delivery of radiation to normal tissues nearby the tumor of interest, the system isn't perfect, and X-rays have to pass in and out of tissues in the beam's path, even if it is at lower doses than what the tumor is getting. It's also important to understand the complications that our patients who received 2D or 3D radiation prior to modern-day techniques may be experiencing. Remember that types of modern-day RT techniques include IMRT, which stands for intensity modulated radiation therapy, as well as a subtype of IMRT called volumetric modulated arc therapy, or VMAT. About 60% of patients diagnosed with gynecologic malignancies will undergo treatment with some type of radiation in their treatment course. A lot of our information about chronic radiation toxicity actually comes from historic knowledge from nuclear accidents or nuclear warfare around the world. Effects on cells resulting in complications from radiation can either be deterministic or stochastic. Deterministic effects tend to occur only above a certain threshold of exposure to irradiation, and severity increases with increased dose. Most organ damage exhibits deterministic effects. Deterministic effects are usually predictable and reproducible. Stochastic effects do not have a minimum threshold at which they start to occur. Doses of any magnitude of irradiation can induce genetic changes which may lead to these effects. A classic example is carcinogenesis. Stochastic effects occur by chance and often may occur many years later. Sydney, can you tell us about the different time terminology of radiation toxicity?
Sure thing. Acute toxicity refers to the side effects that occur either during radiation or within the first 120 days after radiation is delivered. This occurs in the inflammatory phase. Chronic toxicity can be short-term, for example, less than 5 years out from radiation therapy, or long-term, more than 5 years out of therapy. These late or chronic toxicities are in what we call the fibrotic phase. Chronic toxicities are less well documented and described, as many clinical studies will only publish data for 5 years after study completion. Patients with locally advanced cervical cancer are the group who experience the largest burden of radiation toxicities in our gynecology population. Thinking about cervical cancer, where the average age of diagnosis and treatment is about 45 years old, these patients will hopefully have decades of life to live after receiving radiation. It's imperative that we understand how to care for them throughout their lives, not just while treating them for cancer. There is some overlap between acute and chronic symptoms. We'll talk about both today, and we'll organize our toxicity discussion by organ site. Maya, can you start us off by talking about the GI tract toxicities of radiation?
GI toxicity is the most frequent cause of side effects from pelvic radiation in both the acute and chronic phase. GI side effects are also the most likely to affect quality of life and limit daily activities. Acute GI toxicities of radiation therapy include nausea and vomiting early on in the course, with diarrhea and abdominal cramping possibly developing 2 to 3 weeks into treatment. Other potential side effects include anorexia, malaise, rectal discomfort and bleeding, and tenesmus. With definitive treatment for cervical cancer, which involves combining cisplatin with radiation, up to 20% of patients will experience grade 3 or greater adverse events from their treatment course, including a 10% rate of grade 3 nausea and vomiting due to the combination of chemo and radiation. Radiation proctitis occurs in up to 20% of patients, with mostly grade 1 to 2 toxicity. This has improved with the advent of IMRT. Diarrhea in the setting of radiation proctitis can be debilitating. While nausea and vomiting can often be controlled with antiemetics like Zofran or Compazine, prevention strategies have not been shown to be very efficacious for reducing some of the other GI adverse effects. A max total dose of less than 70 to 75 gray to the rectum for external beam radiotherapy and brachytherapy treatments combined is recommended to reduce the rate of radiation proctitis or rectal mucosal injury. Prior abdominal or pelvic surgery is associated with an increased risk of developing small bowel obstructions in patients who receive more than 50 gray of pelvic RT due to adhesions. Additionally, patients with coexisting comorbidities such as pelvic inflammatory disease, collagen vascular disease, smoking history, or inflammatory bowel disease can be at increased risk of developing side effects. Probiotics in a meta-analysis did show a decreased rate of radiation-associated reported diarrhea, but did not decrease the amount of antidiarrheal medications used by patients. Sydney, what are some of the management strategies for these acute GI toxicities of radiation?
Supportive care, including IV fluids, electrolyte repletion, fiber products such as psyllium after completing radiation, a low fiber diet during radiation treatment, and loperamide can help manage acute symptoms of loose stool. For radiation proctitis, topical steroids or steroid enemas can be used. If GI is consulted and performs a colonoscopy or sigmoidoscopy, they may encounter telangiectasias, bleeding, and ulceration. Endoscopic fulguration can address bleeding sites. Chronic GI radiation toxicities are thought to be due to mucosal atrophy, loss of mucin-producing goblet cells, and fibrosis of the intestinal wall. This leads to chronic malabsorption and diarrhea, dysmotility or ileus, and even bowel obstruction. In 12 to 20% of patients who receive radiation for cervical cancer, vitamin B12 deficiency occurs due to malabsorption in the distal ileum, which is a vulnerable location. Maya, how can we manage these chronic GI toxicities?
Chronic GI toxicities often require a multidisciplinary approach with GI, nutrition, and even palliative care. On imaging, we'll classically see thickened and inflamed walls of the small bowel, also known as enteritis. For bowel ileus or partial obstruction, conservative treatment is preferred. Resection reanastomosis may be required if refractory or if there's a complete obstruction. Management decisions will need to balance worsening of chronic malabsorption and poor healing due to malnutrition and compromised tissue. It's important to monitor B12 and other vitamins and to incorporate antidiarrheals. GI bleeding or hematochezia can occur due to proliferative mucosal telangiectasias or ulcerations as a result of vascular sclerosis. This most commonly occurs in the rectosigmoid colon, with a median onset time of 14 months after treatment, but it's still quite rare. A colonoscopy should be done to rule out malignancy, and medical therapy like sucralfate enemas, hyperbaric oxygen, or endoscopic intervention, as previously mentioned, can assist in management. Sydney, can you tell us about the GU toxicities from radiation?
In the urinary tract, acute toxicity is common. Up to 40% of patients will experience grade 1 to 2 acute urinary toxicity. There's wide variation in rates of toxicity, and toxicity is dose dependent. A threshold of 90 gray has traditionally been cited as the maximum dose with tolerable toxicity, although some recent literature suggests that less than 80 gray is necessary to prevent grade 3 toxicity. Acute toxicity can affect all layers of the bladder, manifesting as cystitis, incontinence, and urgency or frequency. Edema can occur in all tissue layers. In the urothelium, we can also see nuclear irregularity and disruption of tight junctions. In the vasculature, patients can develop perivascular fibrosis. And in the muscle, we can see replacement of smooth muscle with fibroblast, increased collagen deposition, and vascular ischemia of the bladder wall. If there's persistent symptoms, a urinalysis and urine culture can be performed to assess for urinary tract infection. Acute cystitis will generally resolve within 1 to 2 weeks following therapy. Interestingly, the bladder tends to tolerate treatment doses of radiation better than the bowel, so patients are often instructed to come to radiation with a full bladder to displace the bowel out of the treatment field. Treatments for acute urinary toxicity include NSAIDs for irritative voiding symptoms, anticholinergics like oxybutynin, or antispasmodics like hyoscyamine for cystitis or bladder spasm, and phenazopyridine, aka azo, for dysuria. Cranberry juice is another anecdotal treatment for dysuria.
Chronic urinary toxicities occur due to epithelial and microvascular changes, leading to collagen deposition and fibrosis and subsequent loss of tissue compliance. Patients can experience a wide array of symptoms. Hematuria or hemorrhagic cystitis with bladder ulcers can be seen with higher total radiation doses, and this can develop years down the road. Management of hemorrhagic cystitis can include continuous bladder irrigation, sodium pentosan polysulfate, but an ideal treatment is not well defined. Fistulization is a feared complication of radiation therapy and can affect both the GI and GU systems. Rectovaginal and vesicovaginal fistulas are the most common presentations and are reported in up to 7% of patients receiving radiation. Having stage 4A disease or a history of tobacco use increases the risk of fistula. Treatments can include hyperbaric oxygen for symptomatic control or diversion for definitive treatment. Ureteral and urethral strictures can occur in 2.5 to 5% of patients receiving radiation. There's a few things that can help prevent toxicities, including contouring of the urethra to use in radiation planning, IMRT technique, and Foley placement, as there's some evidence that bladder distension improves toxicity. Sydney, what GI and GU related complications looked like in our randomized controlled trials for GYN cancer?
These studies confirmed that type and dosing of radiation, as well as modifying delivery fields, really impacts adverse events. In a 10-year follow-up of the publication of PORTEC-1 by Naut et al., Reminder, in which patients received 46 gray of adjuvant EBRT versus observation after hysterectomy for uterine cancer, patients who had received EBRT had significantly higher rates of urinary incontinence, diarrhea, and fecal leakage, with 43% of patients requiring day and night use of incontinence material versus 15% of patients not receiving adjuvant treatment. At 5 years of follow-up, there were no grade 3 or 4 late GU toxicities in the radiotherapy arm, but there was an overall 5% increase in grade 1 to 2 late GU side effects. In follow-up for PORTEC-2, which randomized patients to adjuvant pelvic radiation or vaginal brachytherapy after hysterectomy, vaginal brachytherapy was associated with improved symptoms for diarrhea, fecal leakage, and limitation in daily activities. As we mentioned, dose exposure also matters. The Quantex study published by Kavanaugh in 2010 demonstrated that by limiting the volume of small bowel exposed to greater than 45 gray of total radiation reduces the risk of acute grade 3 or more toxicity. IMRT compared to traditional radiation also decreases rates of toxicity. Klopp et al. In 2018 and Young et al. In 2020 both reported on symptom severity after IMRT versus standard RT. In these studies, acute GI and GU toxicity were significantly improved with IMRT, with 18 to 20% difference in the rates of diarrhea and rates of taking antidiarrheal medications. Which other organ systems experience significant radiation-related toxicity?
Any tissue which radiation has to pass through to reach or after reaching the target organ is susceptible to damage. Another site of potential radiation damage is the vagina. Vaginal toxicity can be really life-altering for patients with atrophy, stenosis, loss of lubrication, fibrosis, dyspareunia, and adhesions. Vaginal necrosis is a rare toxicity which was more common in previous radiation sources like cesium for brachytherapy, or is more common if patients have to undergo a second course of radiation and are re-irradiated. This can be devastating, and treatment options are really limited. In some studies, up to 90% of patients experienced some degree of vaginal toxicity, with severe toxicity in up to 30% of patients. Toxicity is likely to be more severe with definitive management of locally advanced cervical cancer. With high dose rate brachytherapy alone, like for uterine cancer, rates of toxicity are much lower given decreased area of tissue getting irradiated. The distal vagina is more susceptible to radiation injury and resultant stenosis. Management of vaginal side effects is multimodal. Use of vaginal dilators and/or other forms of vaginal penetration, like vaginal intercourse, in combination with water-based lubricants around 3 times a week for at least the first 1 to 2 years post-radiation is really important to help prevent stenosis and preserve vaginal function. Even if patients aren't sexually active, preserving the vaginal opening is important to allow effective ongoing surveillance via pelvic exams to detect recurrence. Sometimes framing it in this way for your patients can help them feel motivated and more comfortable to regularly use their dilators. Other things like vaginal estrogen, vaginal moisturizers, referral to a sexual health clinic, pelvic floor physical therapy, and partner or couples counseling can all be part of the management. What happens to the ovaries during pelvic radiation?
Ovaries are really sensitive to even low total doses of radiation, and oocytes are more sensitive than granulosa or theca cells. Even exposure to 2 to 4 gray can eliminate 50% of oocytes. If ovaries are in the radiation field, as is the case for almost all pelvic RT plans, then premature ovarian failure is a likely outcome. If patients are less than 40 years old, laparoscopic ovarian transposition to greater than 3 centimeters away from the planned field, i.e., greater than 1.5 centimeters above the iliac crest, can be done, and reported success rates in the literature are as high as 80 to 88%. However, it is important to note that transposition itself could include ovarian failure as well. Clips placed on the ovaries can help radiation oncologists identify the new sites of the ovaries, and hormone replacement therapy is an option for patients with cervical cancer after radiation therapy. Skin is also very susceptible to radiation toxicity, as skin cells have about a 26-day turnover. The most common time that we get significant skin toxicity in GYN cancer is in radiation from vulvar cancers. Grade 3 skin reactions are common. Acute toxicities typically occur 2 to 3 weeks into treatment and include erythema, pain, pruritus, alopecia within the radiation field, and even dry or moist desquamation. Management of acute toxicities can include moisturizing creams that should be without dyes, fragrances, or other irritants included, with some such as Vanicream or Calendula cream. Barrier ointments, such as Aquaphor or Vanicream, often used once there's dry desquamation. Topical steroids, such as mometasone and Silvadene cream for moist desquamation. If the patient has had a sulfa drug allergy, then bacitracin or hydrocolloid dressing can be used instead. Additionally, the patient can use sitz baths or medicated soaks from the start of radiation to keep their irradiated area clean and sanitary and to help soothe. Long-term complications include fibrosis, collagen deposition, loss of elasticity, telangiectasias, hyperpigmentation, radiation necrosis, and unfortunately chronic pain. Vitamin E and oral pentoxifylline may help manage chronic radiation-induced fibrosis and radiation necrosis. Maya, what about the effects on bones and bone marrow?
Bone-related radiation toxicities are typically all chronic effects. These include focal osteopenia due to endothelial damage and intimal fibrosis, which reduce blood flow to healthy bone, as well as decreased osteoblast proliferation and metabolic changes with less estrogen. The highest risk area for fracture is the sacroiliac joints, and additional risk factors like older age, pre-existing osteopenia, diabetes, history of oral steroid use, low BMI, and higher radiation doses more than 50 gray also increase the risk. Hematologic toxicity is more severe during chemo-RT. Patients can experience up to a 50% chance of leukopenia and anemia. 25% of our bone marrow reserves are in the pelvis. The importance of sparing the pelvic bone marrow was demonstrated in RTOG 0418, published in 2013. This study showed that the volume of bone marrow receiving 40 gray was predictive of hematologic toxicity. Can you tell us about some emergencies resulting from treatment-related toxicities?
Hemorrhagic cystitis can be an emergency, especially if leading to overdistension of the bladder due to outlet obstruction, as it can lead to autonomic instability and bladder rupture. If this develops, definitely involve urology. Irrigation of the bladder is key and typically involves a three-way Foley. Make sure your patient has 2 large bore IVs for resuscitation and monitor labs for anemia. After stabilization, consider fulguration of the bladder, hyperbaric oxygen, or formalin as a last effort. Bowel perforation is another potential emergency with radiation and may be more frequent in the setting of diverticular disease, appendicitis, or recurrent disease. Surgical intervention with diversion with prioritization of anastomosis of healthy tissue is important, and supplemental nutrition may be necessary. Finally, patients can develop a vascular fistula or GI bleed, which can be life-threatening. If this is suspected, do rapid resuscitation, call interventional radiology, vascular and trauma surgery, as well as critical care. Massive transfusion protocol is often necessary, and remember to stop any anticoagulation. Maya, do you have any final pointers for avoiding radiation toxicity?
Optimizing the use of radiation therapy is critical. In cervical cancer specifically, we know that quality of life and toxicity is much worse when people need surgery and radiation. So if you think a patient is likely to need radiation, don't do surgery. GU fistulas, GI complications, and sexual dysfunction are twice more likely when patients get combination therapy versus therapy with radiation or surgery alone. Review the studies that inform treatment decisions and thoughtfully include consideration of radiation therapy for treatment by discussing with your radiation oncology colleagues. As we've emphasized throughout the episode, newer modalities like IMRT help reduce toxicities when compared to traditional RT by decreasing the radiation dose to normal tissues.
That's all we have for you today. We hope you learned something on today's episodes of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode. About 60% of patients with gynecologic malignancies will undergo radiation therapy at some point in their treatment. Radiation side effects are typically locoregional, whereas chemotherapy side effects are systemic. Patients being treated definitively for locally advanced cervical cancer bear the greatest burden of side effects from radiation therapy as opposed to other types of gynecologic malignancies due to the combination of external beam radiation therapy and internal radiation delivered via brachytherapy.
Acute toxicity refers to symptoms appearing in the first 120 days of treatment. The side effects are generally related to an inflammatory response. Chronic toxicity occurs after that and is generally due to fibrosis and scarring. There's some overlap of symptoms between the two time points, but these are good rules of thumb.
The urinary tract, GI tract, vagina, ovaries, bone marrow, and skin can have side effects, both in the acute and chronic settings. Refer back to our episode for a more detailed recapitulation of those effects.
Conformal radiation therapy, specifically with intensity modulated radiation therapy or IMRT, has greatly improved radiation side effects, particularly with regard to urogenital and GI side effects. Higher doses of radiation and radiation to tumor that's already invading the bowel or bladder typically yield more severe side effects.
Hemorrhagic cystitis, vascular fistula or GI bleed, and bowel perforation are all considered to be potential radiation-related emergencies. Stabilization of the patient and involvement of a multidisciplinary team are incredibly important.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at Ready, Set, GYO.
To support us and our production of future episodes, check out our Patreon at Ready, Set, GYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson. We'd like to thank Dr. Kylie Kang, faculty at the University of Washington, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.